Yes, I will start my presentation. So for this series of webinars.
Dr. Shah, remove your cursor from there. I think you're tapping on it.
Respected seniors and dear colleagues, on behalf of International Society of Manual Small Incision Cataract Surgery, I, Dr. Anil Shah, President for Maharashtra Chapter, welcome you, all the delegates, speakers, discussion on this wonderful series of webinar that is A to Z of Manual Small Incision Cataract Surgery. So for this series of webinar, our aim is to popularize smart SICS. It should be safe, cost effective with minimum learning curve, and it should be useful for community basis. Today is episode 9 and the topic for today's webinar is endothelial protection in manual small incision cataract surgery. Respect corneal endothelium under any circumstances. It is not only a challenge to novice but a seasoned surgeon to protect corneal endothelium. Corneal endothelial protection in manual small incision cataract surgery. It is preserving endothelial health is not the surgical goal. It is a commitment to maintain the clarity of vision and quality of life to our patient. In SICS, each meticulous step is endothelial protection, crafting masterpiece of ocular care. As a surgeon, we are custodian to corneal endothelium and our duty is to navigate the surgical landscape with precision to safeguard its vitality. The journey of SICS is not just removing the lens, it is preserving the delicate dance of endothelial cells, orchestrating the clarity. So for this webinar, we have chairperson Dr. Prakash Marathe, Dr. Anand Pangarkar, Dr. Arvind Moria. For this episode, we have speakers who are expert in their field with the best of their knowledge and experience. Dr. Pradeep Damle, Dr. Girish Gadre, Dr. Rajesh Joshi. And to discuss this topic, we have expert discussant Dr. Nikhil Kandurwar, Dr. Madhuri Dikshit, Dr. Sunanya Malik, and Dr. Mona Deshmukh. I am really very much thankful to all the speakers and discussion for sharing their knowledge. Thank you very much once again. I will hand over to Amiya Kulkarni for further presentation. Amiya.
Yeah. Good evening, everybody. Thank you, sir, for the introduction. And I welcome all of you to this wonderful webinar. It's a fantastic topic when we talk about protecting the endothelium. I think all of us agree with the fact that preserving the posterior capsule is where we start our journey of cataract surgery, and we master it when we realize the endothelium is more important. So I think with that said, I would like to ask Buramani sir if he's present for his views. No. Dr. Sahu, is Dr. Sahu here? Okay. Dr. Parikshit Gopte, if you could please give us your views here.
Well, the endothelium is important, and as you said, it's not the PC, it's the endothelium which counts in the end, because even if the PC is torn, there are ways to do around it. But if the endothelium is damaged, then if we are in a place which does not have an eye bank, well, then we are not in a very good place to be. When we had done a randomized control trial comparing phacoemulsification with SICS, one of the major, what shall we say, the grouse against SICS was, and I remember a very, very famous phaco surgeon saying that SICS will cause endothelial holocaust. So the randomized trials had shown that there was no difference even when HPMC was used for SICS and sodium hyaluronate was used for phaco. And it's not just our study. There is another study by Ronnie George et al. When he was in Vellore, which also is an randomized control trial comparing SICS with phaco with ECC, again, where the endothelial cell count is a major outcome. And that also shows that SICS, like ECC, is very, very safe for the endothelium if proper precautions are taken. So this is an excellent, I think, a topic that is very, very important for all of us and especially for young surgeons, because as Dr. Shah said, respect for the endothelium is perhaps the most important thing that we have to learn as we progress in cataract surgery. Thank you.
Thank you, Dr. Parikshit. I think he's traveling. So we'll go ahead with the program. We have a galaxy of stars today who are chairing the session, who are basically going to talk on this, and then who are going to discuss this particular topic. So I will go through a list of all the CVs. We have people who have not met each other. So I'll just go through the CVs. I won't be taking much long. We'll just run through the CVs. Is my screen visible?
Yes, yes.
Yes.
So we'll start with the chairpersons. It's really doesn't need any introduction. He's one of the stars of ophthalmology in Maharashtra. He's been the past president of MOS, and that is probably one of his achievements. Really doesn't need any introduction. He does a lot of work for IMA. He's a past managing committee member for AIOS. He has the President's Appreciation Award by the National IMA Headquarters, New Delhi. The President's Appreciation Award by IMA Maharashtra State on various occasions. And he's also has the POS late Dr. Asha Kedkar Award by the Pune Ophthalmological Society. I welcome Dr. Prakash Marathe, sir.
Thank you, Dr. Amir.
We have Dr. Anand Pangarkar, sir. A very illustrious career. He's done his MBBS, DO, MS from JIPMER. He was a gold medalist. He's done his fellowship in VR. He has various academic awards and he practices in Nagpur in Eye Infirmary and Laser Center. The third chairman we have today is Dr. Arvind Maurya. He's the first Indian to win a Ophthalmic Star Award at Amsterdam in ESARS 2021, AIOS International Hero Award, first to receive AIOS Senior Academic Achiever Award. He has many best free paper and Colonel Rangachari finalist, and 500 international and national presentations, 100 international and national presentations. So in short, if you go to any national conference, you know who Dr. Arvind Maurya is. Welcome, sir. And our very own Dr. Anil Shah. I don't need to introduce Dr. Anil Shah to the gathering. Sir has various awards, one of which has been conferred twice on him by MOS, is the Innovation Award for his fantastic snare technique the snare that he has developed and the technique that he has developed. Welcome, Dr. Sir. We'll go on to the discussants now. I'll be running through all the CVs so we can get ahead with the program. The first discussion we have is Dr. Sunaina Malik. She's a giant in the field of ophthalmology and specifically ophthalmology teaching. She's an ex-professor and head of Department of Ophthalmology at GMC Nanded and MGM Medical College Aurangabad. She's a PG teacher since 1987. She has a career as a medical teacher and ophthalmologist spanning 45 years. She's the first lady president of the Marathwada Ophthalmological Society and also the president of Maharashtra Ophthalmological Society. She was awarded Best Teacher Award by Maharashtra Ophthalmological Society in October 2015. and she was awarded Dr. Ishwar Chandra Award for Best Comprehensive Ophthalmologist by Maharashtra Ophthalmological Society in October 2022. Welcome, ma'am. We have Dr. Mona Deshmukh, who's done her MS, DNB, and FACO fellowship from MEBEH. She's an ex-associate professor from GMC Nagpur. She's a visiting professor faculty at MEBEH Nagpur. She's also senior consultant at the Meenakshi Eye Center and Hospital Nagpur. Welcome, ma'am. We have Dr. Madhuri Dikshit from Belgaum. Apart from her ophthalmological achievements, one thing that I would like to bring to your notice is she's recently managed to do her MBA in hospital management, and now she is director and runs the Arihant Super Speciality Hospital in Belgaum, which recently was awarded the NABH, full NABH for a multi-speciality 100-bedded hospital. We all know how difficult that is. So congratulations on that, madam. And apart from ophthalmology, she is the only one I know who shifted completely to SICS, being a proficient phaco surgeon, to completely shifting to SICS. So she's one of the leading lights of our society. And in outside ophthalmology, she is also a faculty for art of living and held in very high stead in art of living circles. So welcome, ma'am. We have Dr. Nikhil Kandurwar, who's a DO, DNB, FICO, FCRS, and FSEH. He's done his MBBS from IGMC Nagpur with distinctions in 9 subjects. He was university topper in anatomy and ophthalmology. He's done his DO from Minto Hospital, DNB from Shankara Eye Hospital, Guntur. He's done his fellowship in cornea and refractive surgery from NN, and he now works in Nagpur as cornea and phaco-refractive surgeon. Welcome, Dr. Nikhil. So we go on to the speakers. We have a very senior VR surgeon in Dr. Pradeep Damle, who's a consultant VR surgeon and medical retina specialist practicing for more than 30 years. He's completed his graduation and post-graduation from the BJ Medical College, and then his fellowship from Tel Aviv University, Israel. He's attached to Bharatiya Vidyapit and Symbiosis College. He has his own centers also. So welcome, sir. This is the next speaker is going to be Dr. Girish Gadre. We all know Dr. Gadre. Dr. Gadre was my teacher for vitreoretina as well while I was doing my post-graduation. So he's a postgraduate from the Regional Institute, Bhopal. Sorry. He's done his VR fellowship from Shankara Nethralaya, Chennai. He works as a consultant ophthalmologist in the districts of Kudal and Ratnagiri. He's an associate professor at Krishna Institute of Medical Sciences, Karad. He's received Best Paper Award in MOS. He's received BJ Limai Award twice in State Conference and also the YC Pandit Research Award in State Conference. Welcome, Dr. Gadre. And last but not the least, we have Dr. Rajesh Joshi. He's professor and head of Department of Ophthalmology, GMC Nagpur, editor of JCOR. His area of interest is cataract and refractive surgery. So I welcome you all. And should we start with the presentation, sir? Anil, sir?
Yes, you can start the
Yes.
presentation.
So I welcome all of you. It is a great honor to be amongst you and to listen to all of you. So first of all, I'd like to invite Dr. Pradeep Damle.
Thank you. I'll start sharing my screen. Is it, am I audible and is the screen visible?
Yes,
Yes, sir. You're audible and the screen is visible.
Yeah. Thank you. Good evening, everybody. At the outset, I would like to thank the organizers for giving me this opportunity, especially Dr. Anil Shah and Dr. Prakash Marathe, and all the chairpersons of SICS. Today, the topic given to me is OVDs, theoretical considerations, merits and demerits. Ocular viscoelastic devices are transparent gel-like substances which have both viscous and elastic properties. In 1972, Bola has developed and coined this procedure as viscosurgery. He presented the patent of purified hyaluronic acid as the viscoelastic material and sold the patent to Pfizer, and this company developed Helon as the first viscoelastic agent. They have a range of features with rheologic related properties like elasticity, which is the ability of the solution to return to its original shape after being deformed. This allows the anterior chamber to reform after depression of the cornea when the external forces are released. Best example is sodium hyaluronate. Viscosity is the resistance to the flow and is determined by the molecular weight. It denotes the protective and lubricant action of OVDs. Pseudoplasticity is the ability of the solution to transform from gel to liquid when under stress. This enables easy injection and removal of the agent from the eye. Cohesiveness, this determines the coating ability of the OVD. Lower the surface tension, better is the ability to spread and coat. These molecules are more adherent to each other. Dispersiveness is the tendency to adhere, they have less tendency to adhere to each other. And it indicates low molecular weight, low surface tension, low pseudoplasticity. Rigidity is complex viscosity. It is the resistance which is felt while maneuvering any object instruments through the visco. Surface tension is the property by which it coats the surface. Low surface tension and low contact angle, these substances have better coatability. And finally, adaptability. It is the change from the supraviscous state at low shear rate to a pseudo-dispersive state at a higher shear rate. The best example is Helon 5 or Helon 5 Pro. So if you want an ideal viscoelastic, it should be optically clear. There should be ease of infusion and removal from the eye. It should not interfere with instruments or IOL. It should be chemically inert, non-toxic, free from particulate matter. It should protect the endothelium. It should maintain space even with instrumentation and shouldn't obstruct the aqueous flow. The compositions which we have, the first one was the sodium hyaluronate, which is a salt derivative of hyaluronic acid, which is present in the connective tissue of bacteria in humans. It was first extracted from the vitreous humor of cows. Commercially, it is available now from the rooster combs and the streptococcal bacterial culture. Viscosity is 30,000 to 10 lakh, 1 crore centipoise. Chondroitin sulfate has more or less properties which are similar to sodium hyaluronate. It is commercially derived from the shark fin cartilage, and it is found in the cornea as one of the 3 mucopolysaccharides. Hydroxypropyl methyl cellulose, which is the cheapest one available, it is the cellulose derived and extracted from the plant fibers like cotton and wood. The viscosity is 3,000 to 4,000 centipoise. So we have a spectrum of viscoelastic. On one side, we have dispersive OVDs, which have the ability to coat and protect. And on the other side, we have cohesive, which have the ability to maintain and space and pressurize the air. And in between, we have the combo OVDs. So if you look at the cohesive agents, they are long molecular chain, high molecular weight, high degree of pseudoplasticity, and high surface tension. They pressurize the eye well and they create space, and they are ideal during capsule or excess and IOL insertion. They are easy to remove because they come in a bulk. They come out in one bolus sort of. The best examples are Helon GB and Amvisc. Dispersive agents are they are of lower viscosity, low molecular weight, lower surface tension, and lower pseudoplasticity. They coat the endothelium well. They are ideal for soft shell technique. We'll discuss it later. Lubrication of the injector cartridge. The names are Viscoat, OcuCoat. As name suggests, they have coatings of the wall, coats, Helon D and Appavisc. We have visco adaptive ones. Now, they are pseudo-dispersive, ultra-viscous cohesive. They are at low flow rate, they are more viscous, and at higher flow rate, they become dispersive, actually protecting the endothelium. Helon 5 Pro is the best example of it. Then we have combination, where the single agent which has both cohesive and dispersive properties. One is the Discovisc with sodium hyaluronate and chondroitin sulfate, Duovisc, which combines Viscoat and Provisc, Amvisc plus 1.6% sodium hyaluronate, and Visthesia, where 5% sodium hyaluronate is combined with lidocaine, and it gives better anesthesia because the viscous, the lidocaine remains in the eye for a longer time. Then we have OcuGel, which is a combination of HPMC with chondroitin sulfate. It has better viscosity and coating, requires but a large bore cannula. Collagen is derived from the human placental collagen. This 2% solution is a protein as compared to other viscoelastics, which are polysaccharides. And Cellugel, I think probably it is from Alcon, is a synthetic polymer of modified carbohydrate. It can be autoclaved, and it also can be stored at room temperature, and it can be injected through a 25 gauge cannula. The newer viscoelastics, polyglyma, I think this was tried, but it is found to be toxic. But polytegma, the triethylene glycol monomethacrylate, can be a future. This can be available in future as a viscoelastic. These are various preparations of sodium hyaluronate. So indications which can in cataract surgery, the cohesive ones can help in to deepen the AC in all cases, but more so we need them in hyperopic eyes. They can cause viscomydriasis. They can break anterior synecdoche if they are of loose type. They can stabilize the anterior capsule if the rhexis is running out. And in floppy iris syndrome, they can stabilize the iris. They can also prevent the iris prolapse. Whereas dispersive, they will coat the endothelium. Even they can be used to isolate area of zonular disinsertion and in posterior capsular rupture as a barrier between the two segments. In other uses, they are useful in maintenance of the anterior chamber, protection of endothelium. They will flatten the anterior capsule during capsular access, and they will provide good coating and implant while during implantation of the IOL with ease. Even they can prevent entry of blood and fluid in the anterior chamber through the tunnel. They can prevent vitreous from coming into the anterior chamber in PCR. In glaucoma surgery, we can be used for viscocanalostomy to open the Schlemm's canal. In keratoplasty, they can protect endothelium. They form the anterior chamber or help in trephination, release adhesions. Even in DALC procedures, they can be helpful in removing the layers till the Descemet's membrane, or even for DM scoring in DMEC and DSEC procedures. Other controversial, I would say, retinal detachments, Girish would be able to a better person. They can be used in removal of fibrovascular bands and ILM peeling, but I haven't seen anybody using it. Repair of globe in perforating injuries. In glaucoma, it has also been mentioned that it is used to inject in the anterior chamber to prevent hypotony the next day, or even in subconjunctival space, I would to form the bleb in trap cases. But I haven't used it, but I think this would be a good thing to discuss if anyone is using this as a viscoelastic agent for these procedures. They have been a boon and they have revolutionized the cataract surgery. But if they are left inside, they can cause side effects. And the most important one is the postoperative IOP spike, which is mostly seen in 24 hours. And but it resolves in a week's time. Crystallization of IOL surface is also seen in some cases, where the viscoelastic gets deposited on the lens surface, and it takes a firm or amorphous pattern, and most of the times requires IOL exchange. Capsular block syndrome, it can be divided into 3 types. One is an immediate one where you inject while doing hydrodissection, and the BSS goes into the capsular bag and pushes the nucleus and the epinucleus upwards, causing capsular block. Or it can sometimes be seen during operation, after the operation, where the viscoelastic remains behind the IOL and pushes it upwards. And in late phases, maybe viscoadaptive viscoelastic along with some capsular remnants with liquefaction of the capsule can cause late post-op capsular block syndrome. We can have pseudo anterior uveitis because of the viscous nature and negative electrostatic charge. Blood and inflammatory cells can remain suspended in the anterior chamber, causing pseudo anterior uveitis, but this resolves in 3-4 days time. Corneal edema is seen in some cases. Calcific band keratopathy is especially seen with chondroitin sulfate, and hypersensitive reactions can be seen especially with sodium hyaluronate because it is a bacterial protein. Helpful techniques, soft shell technique, which was described by Steve Arshinoff, where a dispersive visco is injected in the anterior chamber and cohesive put on the lens surface, and this pushes the dispersive visco against the endothelium. Then there is a soft shell technique where first you inject a dispersive and then viscoadaptive is injected below it. And the third one is ultimate soft gel technique, where a viscoadaptive solution is injected into the anterior chamber and BSS is injected below this over the anterior capsule. This is a cost saving technique of all the three. Tips and tricks for the beginners. Whenever we inject viscoelastic into the anterior chamber, we see this spaghetti-like or a pasta-like appearance. So to get rid of it, you push the plunger faster, and you will see a wave which will remove all these, and the clear capsule, anterior capsule, can be visualized. Some other things: thickness of the posterior capsule. I would say it is 3.5 microns. Even the red blood cells are 7 microns. So don't inadvertently touch it. It is very difficult because most of the time when you see the capsular or any posterior capsular or cortex remaining on the posterior capsule, if you try to remove it through the main incision, most of the viscoelastic has already been removed at this stage, and the chamber suddenly shallows, and the posterior capsule comes upwards and cause PCR. It is very safe to polish it through the side port. So if IOP is raised in 24 hours, retained visco is more likely. If it is seen after 2 weeks, then this patient may be a steroid responder. If you are removing the nucleus with a vectis, inject visco beneath and on the top of the nucleus so that you will have a space to put the vectis inside, and also it will not touch the endothelium while coming out. Second part of it is the pull the vectis in a downward and outward direction. The base of the handle should be facing downward. Most of the times I've seen students who are, when they start getting the nucleus out, they tend to pull it upwards, and that can rub against the endothelium and damage the endothelium. Endothelial cell count at birth is around 5,000 cells, which in adulthood it reaches 2,500 and keeps on depleting. So we have to take care of the endothelium. All visco has to be removed, especially in toric cases, toric IOL, where the IOL sticks to the bag only if the visco has been removed. If some amount of visco remains in the bag, this IOL can rotate. Beginners, I think they can, to remove the viscoelastic, can tap the IOL to remove it. You can have a spinning technique where you can rotate the IOL and remove the viscoelastic. And once you become experienced, you can have a rock and roll technique where you can lift the optic and go beneath and remove the viscoelastic and give wash. Thank you for patient hearing.
Thank you, sir, for a wonderful presentation. So it was very informative and exhaustive. I would now like to call upon Dr. Girish Gadre, sir, to give his presentation, please. Sir, you're muted. You can please unmute yourself.
Hello.
Yeah, we can hear you, sir.
Yeah, am I audible?
Yes, sir.
Yeah. I will share my screen. Is it visible now?
Yes, sir. Your screen is visible.
Shall I start?
Yes, sir.
Good evening, everybody. I am Dr. Girish Gadre. I'm a vitreoretinal surgeon. And I would like to thank Dr. Anil Shah, sir. Basically, this topic was given to Dr. Shekhar Paranspe, sir, initially. But due to his unavailability, due to his sport event, he has asked me to present this topic. And even though I'm a vitreoretinal surgeon, recently, just a month back in the MOS, I have presented one paper on non-visco phacoemulsification surgery. Possibly, he might have seen that paper and asked me to present this topic of AC maintainer in MSICS. Just now, Dr. Damle sir has already discussed in details about OVDs, and extremely well he has explained use of OVD for the endothelial protection. But basically, viscoelastic is used in all surgeries to maintain space during different manipulations like CCC IOL implantation. It enlarges and stabilizes the size of pupil and helping hemostasis and protect corneal endothelium. All these properties are due to maintenance of anterior chamber, which can be possible by using anterior chamber maintainer or anything which can maintain anterior chamber. All these properties can be used. So the AC maintainer is first introduced by Blumenthal in 1987 by his mini nuke technique, which provides a high pressure, high flow system that would help to maintain the anterior chamber space during anterior segment surgery and hence protecting the important tissue structures and preventing different iatrogenic damages. It involves minimal intraocular manipulation and can be used to perform different surgeries. Dr. Ravi Thomas said that anterior chamber maintainer allows anyone to learn SICS almost without a learning curve. These are the different references where they have said that viscoelastic is not of instead of viscoelastic, one can use anterior chamber maintainer and do the surgeries. Definitely, when I'm presenting this topic, I'm not against viscoelastic. It needs to be used whenever it is necessary. But it has been during our learning phase, we are using viscoelastic like anything. Like in each and every step, we are using viscoelastic, and we have been taught that it is like a like when you use that is going to help in the surgery. But sometime, as Dr. Damle sir has already said, there are a lot of side effects of viscoelastic also that can be completely avoided by not using viscoelastic. So AC maintainer can be used in various procedures, including cataract, anterior vitrectomy, IOL related procedures, different corneal procedures. It can also use to decrease and eliminate use of viscoelastic in selected cases. It can be used as a cost containment approach, particularly when we are talking about SICS. It is basically a cost effective procedure, and use of anterior chamber maintainer is highly effective, reproducible in all grades of cataract. So theoretically, I'm not going in much details, but I'm just showing few videos which we can do under AC maintainer without use of visco. Different types of anterior chamber maintainer, different options are there. Of course, I have not used all of them, but my favorite one is the right one, this one, which I'm going to demonstrate in my videos. Now I'm just showing 5-6 cases of small incision cataract surgeries in all grades of cataracts, particularly all are near mature cataract. In all cases, because it is a positive pressure surgery, anterior chamber is very well maintained, and we can do very controlled CCC. And because positive pressure is maintained, there is a least chance of PCRN because it is always taut and go posteriorly. Because anterior chamber is very well formed and deep, there is lot of ease in different maneuverability in the anterior chamber. So all procedure we can do in anterior chamber under anterior chamber maintainer. I preferably used wire vectis. And because it is a positive pressure surgery, there is a least chance that there is an ingress of any fluid from outside, and because there is less hypotony, it is more safer to do all the surgeries. So I always prefer to use AC maintainer. A well-maintained anterior chamber helps to achieve capsular axis of optimal size and shape at the best possible location. There is a lot of thought that viscoelastic is necessary, but in all my mature cataract cases, even they are all phacomorphic cases, AC was very shallow, still we can do capsular axis very easily under anterior chamber maintenance. We can rotate nucleus, bring it into AC, and there is no possibility that there is a PC rent because due to AC maintainer, anterior chamber is very well maintained and we can do all maneuvers very easily and safely. Aspiration of subincisional cortex too has always been very difficult task which can be very easy under anterior chamber maintainer. Even IOL implantation is also easy because AC is very deep. Here I have not stained anterior capsule because it's a Brunus and near Brunus cataract. Actually, in rest of the cases, I have stained with a Blurex just to demonstrate because I'm showing it in the video. Otherwise, it is not necessary to even stain the capsule because when the fluid flow is there, the capsule is turning and having some flickering movement, which is very clearly visible. So there is no need of use of even Blurex during surgery because the anterior capsule is very clearly visible because of its movement. Hydrostatic force of a fluid in the anterior chamber guides the nucleus to the wound by just pressing posterior lip of wound with a Vectis, which usually we use by using a visco cannula when we use visco expression, when we remove nucleus by visco expression. Even in all cases, I have used different kinds of intraocular lenses like preloaded lenses. Sorry. This is a hypermature cataract where we usually use high viscosity viscous OVDs, but you can see you can do CCC very easily. A small tag of CCC was there, which I could remove with a Vanas. The problem with the anterior chamber maintainer is that there is a very high chance that there is a iris prolapse because fluid turbulence is from inferiorly towards wound. So if iris is floppy, in that case, it is better to use visco to reposit that iris. Okay, so you can use visco whenever it is necessary. Now, as I said, because we are not using visco, so least chance of entries and exit. So least manipulations are there and there is no ingress of fluid from outside because it is a positive pressure surgery. So there is a less chance of infection because the most common cause of endophthalmitis is our own bacterial flora in the conjunctival sac, which enters during surgery through our wound because of ingress during hypotony. So there is no hypotony during any of this procedure when we use AC maintainer. So infection chance is also reduced by using AC maintainer. That itself can help as an endothelial protection because manipulations are less. So that will help to protect endothelium. There are a lot of journals which shows that endothelial loss is there in SICS, as Dr. Parikshit sir has said. But comparably, if we see, there are many journals which show that SICS and FECO do not have much difference, clinically significant and statistically significant difference in endothelial cell loss. Now, in my MOS presentation, actually, I have done comparison in a patient where we have used visco and non-visco FECO, and we have done endothelial count in around 58 patients, 28 each, and we found that there is no clinically significant difference, statistically significant difference in two comparative cases. And actually, I have done it for FECO, but same thing we can do, that same study we can do for SICS. And we found that there is no much endothelial loss when we use irrigation, and we have not used visco. And there are a lot many papers which have shown that without visco, we can do surgery without much endothelial cell loss. Now, there are some other kinds of anterior chamber maintenance like 23 gauge trocar and cannula. Actually, I tried it. Dr. Amar Agrawal has actually presented this in All India conference, and he has also published it. But I won't feel it is that helpful. The reason is that the tip of the trocar is very long. So there is a very high chance that it may damage anterior capsule inadvertently. He actually used it through pars plana, 1.5 millimeter away from limbus. But I feel that is a bit dangerous because if we go slightly posterior, we may hit somewhere in the trabecular meshwork or ciliary body. So I personally won't feel that 23 gauge trocar are that comfortable as an anterior chamber maintainer for doing these surgeries. But definitely, like he found that it as a ease. So some surgeons may use it and try it for the anterior chamber maintainer. The basic advantage I found that because it is from the left hand side, the superior force of fluid which is coming, that can be reduced. So the chances of iris prolapse can be reduced by using this. Sorry. My last video, rather than using AC maintainer, we can use simple irrigation. And that irrigation itself act as an anterior chamber maintainer, and that also act as a second hand. And that helps to and has a same advantage. This is a case of FECO, actually speaking. But I would like to show that it helps as a second hand as well as it maintains anterior chamber. And we can avoid viscoelastic completely. The space is so large that we can even tilt that lens completely without touching endothelium. That only I want to show. And same thing we can use in SICS. Rather than using anterior chamber maintainer, we can use side port and through which irrigation can be used, where anterior chamber can be maintained without use of viscoelastic. So no use of viscoelastic will have advantage that there is a difficulty in visco removal behind IOL. So that can be completely solved because we won't use visco. So many of the entries and exits can be avoided. Time can be saved completely. There is no postoperatively IOP rise. There is no chance of tasks related to viscoelastic. Cost of surgery is reduced, and most important is time of surgery is reduced, because if you see 1/3 of our time we usually waste by removing and injecting viscoelastic. That can be completely saved, and because of less manipulation, I feel we can protect endothelium because of that. So to conclude, cataract surgery can safely be performed without use of viscoelastic. Of course, I am not against of viscoelastic, but just use viscoelastic like anything. We can use whenever it is necessary. It has an added advantage of controlled surgical procedure in deep positive pressure chamber. Least entry and exit from anterior chamber and continuous turbulence of fluid reduces fluid ingress and thus infection. It is a time and cost saving. Postoperative side effects of viscoelastic can be completely avoided. Thank you very much. I'm not actually SICS surgeon. I'm still learning SICS. I'm a vitreoretinal surgeon, and still I feel that SICS surgery is much difficult than vitreoretinal surgeries. So I would like to learn from all of you, and through this is a very good platform where I can learn SICS surgeries. Thank you very much.
Thank you, sir.
Excellent surgeries, excellent videos.
Yes.
Excellent
Thank you,
videos,
sir.
sir. Very nice.
Thank you. Thank you.
Fantastic videos.
I would like to learn, and I would like to know what things I have done wrong during my SICS.
No, sir, you are a super surgery.
For somebody who's actually witnessed your surgeries firsthand, sir, I know it is your humbleness when you say you don't know a certain surgery, right from your VR surgeries to everything that you do. Wonderful presentation, sir. Very good videos, very clear videos also. So I congratulate you on that.
Thank you, Amay. Thank you. Thank you for your kind words.
I would now like to call upon Dr. Rajesh Joshi, sir, to start his presentation.
Thank you. So I am visible as audible.
Sir, you're not audible. I think there's a problem with the connection. You're breaking up, sir. The audio is breaking up.
My video.
No, audio.
Sir, audio is breaking up. If you could switch off your video, we probably would have more bandwidth for the audio.
Yeah, let me see.
Rajesh, just say something. Then know whether the audio is okay.
Now audio is okay?
Yes.
Yeah.
Good evening, everyone.
Yes.
Yeah, at the outset, I thank Dr. Anil Shah, President of International Society of Manual Small Incision Cataract and all the office bearers of talking on irrigating fluids, normal saline, ringer lactate, or BSS. Nothing to disclose. What is the ideal irrigating solution for cataract surgery? It should be stable. I mean, it should not give rise to any post-op reaction. It should be inexpensive, as the cataract surgery is most commonly performed surgery throughout the world, and all the surgeries needs irrigating solution, so it should be inexpensive. Composition should be similar to aqueous. These are the main things which are important for any irrigating solution used for cataract surgery. Now, these are the various irrigating fluids which are used for cataract surgery, that is ringer lactate, normal saline, balanced salt solution, and balanced salt solution plus with oxidized glutathione. The first two are off-label because they are already used somewhere for other purposes also. So the main solutions which are used for cataract surgery are balanced salt solution and BSS plus. If we see the components of the solutions, the ringer lactate has potassium, calcium lactate, and it is acidic, which may cause problem to the corneal endothelium. And if you compare the components of balanced salt solution and ringer lactate, it has got balanced salt solution has got magnesium, ATPase endothelial pump, which is essential to cause the dehydration of endothelium, and acid citrate buffer system, and it is alkaline in pH, which is friendly for corneal endothelium. And BSS plus has got all the components of BSS plus addition of glutathione, glucose, and bicarbonate. Now, if you compare the BSS plus with BSS, aqueous, and vitreous humor components, the BSS plus has almost similar components to that of aqueous humor and the vitreous humor. And some of the components are lacking in BSS. So BSS is supposed to be the ideal solution which should be used for cataract surgery. Now, why so much stress on using proper irrigating solution in cataract surgery? As you know, corneal endothelium is a single layer cell with limited or no regenerative power. If there is a loss of corneal endothelium, the gap is filled by expanding existing endothelium. The corneal endothelium is important for corneal transparency and visual outcome after cataract surgery. The natural loss of corneal endothelium is 0.6% per year. And if your surgery causes corneal endothelial loss, there is likely to have some corneal decompensation in few years to come after cataract surgery. Intraocular manipulations can lead to damage to the endothelium. So that's why there is a stress on proper use of irrigating solution and the viscoelastic solution in the cataract surgery. Now, I went through the literature because the literature available for the ringer lactate, BSS and BSS plus is meager. So whatever literature available, I'm giving you the review of this literature. Now, comparison between ringer lactate and BSS in cataract surgery. This study was published in Indian Journal of Ophthalmology 2009, which was done by our own Dr. Vasavada. It was a prospective observational study in eyes undergoing phacoemulsification for senile cataract. And what were their observations? BSS has shown lesser corneal endothelial thickness and inflammation compared to eyes receiving ringer lactate in immediate post-op period. However, no statistical difference was seen between BSS and ringer lactate at 1 to 3 months post-op period with these parameters. So all the parameters which were studied with BSS and RL, they were not significant after 1 and 3 months post-op. Now, there was another study which was published in Archives of Ophthalmology, BSS plus versus ringer lactate solution. This was the study in the laboratory. The human corneas which were removed after enucleation were kept immersed in ringer lactate and BSS plus for 3 to 4 hours. BSS plus showed normal corneal thickness and endothelial integrity compared to ringer lactate, which showed various degrees of endothelial cell breakdown and corneal swelling during 3 to 4 hours of perfusion. What was the conclusion of this study? BSS plus is better solution for cataract surgery. Now, after looking at this experimental study, researchers, they took another topic comparing the ringer lactate versus BSS plus. In vitro corneal endothelial cell exposure was done with ringer lactate, BSS and BSS plus for 50, 30, 60 and 120 minutes. In long-term exposure for corneal endothelium with ringer lactate resulted in swelling of endothelium than BSS and BSS plus. The conclusion of this study was that if you are performing cataract surgery or you're in complicated cases or you expect that your surgery time should be more, you should use BSS or BSS plus. Comparison between BSS plus and ringer lactate. This study was done in uncomplicated phacoemulsification cataract surgery. Results showed ringer lactate solution is associated with corneal endothelial loss similar to BSS plus. Cataract surgery requiring higher volume of irrigating solution and longer surgical time, BSS plus contribute to lower endothelial loss. That was the conclusion which was showed during the comparison between BSS plus and ringer lactate. Now, corneal endothelial protection during cataract surgery with ringer lactate, hydroxypropyl methylcellulose, we compared with chondroitin sulfate plus sodium hyaluronate and BSS. This study was done in senile cataracts. No difference was noted in two groups in acute post-op corneal edema and endothelial cell morphology in two groups. At 3 months follow-up, no count and morphology. However, the cost of surgery was huge in group 2 as sodium hyaluronate and BSS plus was involved. That was the conclusion of this study. Now, effect of ringer lactate versus BSS plus on intraocular inflammation. As after you complete the cataract surgery, the ringer lactate or air bubble or whatever irrigating solution which you are using during cataract surgery, that will stay inside the eye till the aqueous humor replenishes that fluid. Now, what this study says, these three solutions were studied in cataract surgery for development of post-op inflammation. The flare in anterior chamber was measured with laser flare meter after cataract surgery in 3 groups. The conclusion of this study was lower values of flare and cells was seen in all 3 groups. However, BSS and BSS plus group had less cells and flare in post-op period compared to ringer lactate. Now, what are the AIOS guidelines for irrigating solutions used in cataract surgery? BSS and ringer lactate are equally effective, but ringer lactate is off-label for cataract surgery. So this should be kept in mind. Sterilization of sealed bottle is not required. If a glass bottle is used to vacuum test, the vacuum test is once you put the saline inside the drip, it sets in bubble inside the drip. Antibiotics in irrigating solution is not required. A routine practice of preserving the bottle for 24 hours before being discarded to look for possible growth of microorganism is recommended by on AIS guidelines for irrigating solution. Now, conclusion from whatever I have said is stick to irrigating solution with which you are comfortable in terms of postoperative inflammation and endothelial protection. So this is all about irrigating solution. Thanks for your patience listening. My special thanks to Dr. Mona Deshmukh while preparing this talk. Thank you.
Thank you, sir, for the wonderful talk. We are through all our talks, and our founder chairman, Dr. Amulya Sahu sir, joined us between the talks. So I would like to call upon Dr. Sahu sir to give his thoughts, sir. So you're muted, so please can you unmute?
I'm enjoying the talk. Let them continue.
Yes, sir. I call upon Dr. Prakash Marathe, sir, to start the discussions.
Yeah. Thank you so much, Dr. Amir. Our chairperson, Dr. Sahu sir, Dr. Boramani, then Maharashtra President, Dr. Anil Shah. Under their leadership and their guidance, I think we have designed this webinar in a wonderful way. Everybody must have realized today that this was the theoretical topic. Basically, we thought it may get bored or boring type webinar, but it wasn't. Wonderful presentation on various aspects by Dr. Damle about viscoelastics, and Girish Gadre showed the fantastic videos. I think he's the known VIA surgeon, but the SIS surgery was not far behind. He, I think, is the generalized specialist, I should say, VR as well as anterior segment. So fantastic videos, how AC maintainer can be utilized in SIS surgery was very well demonstrated by him. And theoretical topic which was discussed by Dr. Rajesh about various solutions. I think SICS and FECO most of the times when it is compared, FECO people especially, they feel that there is handling in the AC at the time of SICS surgery. And basically, endothelium probably is at risk, what everybody feels. There are various techniques like nucleus rotation, then snare technique, which is used by Dr. Anil Shah. Most of them, they feel that because it is handling in the anterior chamber, probably endothelium gets compromised. But I don't think so. Even the studies, as Dr. Gadre said, that comparison has shown that SICS and FECO, there is no much endothelial cell count difference, and it is almost the same. And we have seen the results in experts' hands. Basically, this webinar was very useful for beginners, like youngsters. They should get that confidence. And when they feel that AC maintainer is not of use, I think that was the demonstration. Blue menthol, everybody has seen. So fantastic AC maintainer use is there. And so many surgeons are there, they're not touching the visco. But role of visco is very, very, very important to protect your corneas. And I think end result of your SICS surgery or FECO surgery is not just to remove the nucleus or remove the cataract and to put the IOL, but keep and maintain that endothelium. My important question to Dr. Girish Gadre is, are there special situations, in spite of you being the lover of AC maintainer, I should say, when you use viscose?
Hello?
Yeah, Girish.
Yeah. Sir, I am not against viscoelastic. As I said, when I feel that iris is floppy, where iris is getting prolapsed, it's better to like reduce bottle height and use visco. So that situation, we have to use visco, reduce bottle height of AC maintainer, because when there is a floppy iris, it will go on coming into wound, and we may damage during repeated reposition. So in that scenario, we have to use viscoelastic. And particularly when AC is very shallow, particularly phacomorphic glaucomas, where it is very difficult to put AC maintainer, we can use first visco in AC and then put AC maintainer, where we can use AC maintainer.
Fantastic. I think these are the important situations. One important thing is when there is a compromised cornea to start with.
Obviously, yes, definitely.
So I think this is all from my side. Over to other chairpersons and discussants and experts.
Thank you, Marathe sir. I would like to ask Dr. Anand Pangarkar sir to give his thoughts on this.
Welcome, Dr.
Hello.
Boramani.
Thank you.
Anand, you're not visible.
Dr. Pangarkar sir, bola.
No, I thought Anil Shah welcomed Dr. Boramani, so I thought I will let him speak. First of all, when I discussed with Anil about the topic of tonight rather, I thought that it will be very useful, and all the three of them, Pradeep, Girish, and Rajesh, have done excellent. Girish's videos were great, and nowhere, as Dr. Marathe has said, that was it apparent that he is trying to learn SICS. Rajesh has done a commendable job about this, giving the theoretical aspects. And what I thought that I could add something is, not everything is good about the AC maintainer, Girish. Means I agree. I'm not using it, but I have used it. The increased chance of endophthalmitis because the wound is unprotected. The wound that you create in the lower limbus for the maintenance of the insertion of the AC maintainer. But apart from that, AC maintainer gives you really good results. And if you don't want to engage yourself in the hassle of removal of OVD later on, then of course AC maintainer is great. The question, after having listened to all this, is which irrigating fluid will you use if the patient has a borderline endothelial cell count, is advanced in age, the nucleus is got grade 4 nuclear sclerosis, and to increase your difficulties, the patient is one-eyed. In all these conditions, whether you would use an OVD or you would use a AC maintainer, and which irrigating solution would you like to use? The statistical interpretation of the endothelial cell loss and the alteration in the endothelial cell function, the possibility of corneal decompensation because of endothelial cell damage, are all things which are partly covered in all these research papers. And one more factor which gets overlooked is that apart from the composition of the fluids or the viscoelastics that you use, it is the turbulence caused in the anterior chamber which also contributes to the endothelial cell loss or endothelial damage. So despite all these inputs, these questions are there, and some of these answers are left perhaps to the choice of the individual surgeon.
Ame, can I just say something? Can I add something to that? Dr. Girish, your videos were fabulous. I mean, as Dr. Pangarkar said, and Dr. Marathi also said, nobody seeing them would believe that you are a VR surgeon and not a cataract surgeon. They were so good. You handled, I think, even, completely mature cataracts with such ease, even where the iris was prolapsing out. And this is the point I wanted to make. I have attended Blumenthal's lecture in Mumbai when he first started out with his AC maintainer. I think I'm that senior. So I was very enthusiastic about it. I even bought one right there and then, came back, started using it. But somehow my experience with it was not very good because I felt that all the time it's making the iris come towards the wound, and not only in floppy iris cases, in most of the cases. So I went back to my original OVDs and stopped using the AC maintainer. I still have it in my armamentarium, but I don't use it anymore. Maybe after seeing you, I might get inspired to start using it again. Or I might have to come to you to learn to how to use it.
Just to add one thing, sorry to interrupt. I think to put AC maintainer needs some expertise. It is
Yes.
not that easy. It is not that easy. Take it from me.
I agree totally with that. It's not easy for a.
Can I say something?
Yes, Anand, go
Hello?
ahead.
I thought, Girish, you showed all those videos which were more or less carrying the same message. But had you put a small little video clip of how do you insert your AC maintainer, that would have helped. Perhaps the angled MVR blade to make the entry and to get a good corneal tunnel before you actually enter the anterior chamber, then the direction of the anterior chamber maintainer's tip and the bottle height. Are all these things, Dr. Sunaina, means you can take it as a tip that in case your iris is coming out, perhaps your bottle height is more, or your main entry wound valve system is not so good. So if all those things are done, and that angled MVR blade I found very useful in making the AC maintainer entry.
That's a good tip.
And its stability depends on actually the cord length of the corneal canal.
Dr. Boramani, you wanted to make a point here?
Yeah. I think I must have used maximum AC maintainer, or in other words, right from 1998 onwards, I have not done any cataract surgery without AC maintainer. AC maintainer is the first thing to go inside in my cataract surgery and the last thing to come out. And most of the times, AC maintainer is kept on throughout the procedure. There are few situations wherein you have to use viscoelastics and stop AC maintainer. Otherwise, many a times, almost say 70-80% of the surgeries can be done without any viscoelastics. There are tremendous advantages of, sorry, I'm having a little bad throat. There are tremendous advantages of AC maintainer. First of all, the worry of endophthalmitis, because you are creating one more side port. That is only disadvantage of AC maintainer. But this port is not a radial one like other side port. This is a tangential, almost tangential. So that I don't think it contributes to the risk of endophthalmitis. People are doing superior incision, it goes almost in the near the lower cortex. But otherwise, at least for in my cases, the position can be nasal, temporal, and different places. That is one thing. Second thing, Dr. Pangarkar, I think he talked about the turbulence. AC maintainer doesn't count any turbulence in the entry chamber because the entry chamber is full of fluid. In AC maintainer just instantaneously replaces the fluid, whatever has come out, without turbulence. Because I can show you innumerable videos where I am doing surgery. There is a small air bubble in the center of the cornea, and that is rock steady. Because it is because of the instantaneous replacement of fluid. Turbulence is not there. On the contrary, with phaco end piece, with that irrigating phaco end piece, you are dancing with the phaco end piece and moving it in various directions in the entry chamber. That might be causing more turbulence along with the turbulence of the ultrasonic damages. Second thing, one more interesting thing about AC maintainer is that I think most of us know what is your general presumption. How many people, cataract surgeons, must be using AC maintainer? It should be less than 10, less than 5%, isn't it?
Less than 5.
But when Dr. Purvi Bhagat did an all India survey about different things in the cataract surgery, it was extremely surprising that in her survey, it was found that more than 80%, I don't know the exact figure, but it was more than 85% who were using AC maintainer. I don't know how that has come. It's extremely surprising.
Very surprising.
It is very surprising. Thirdly, Dr. Gadre has talked about doing CCC under AC maintainer. You can do CCC completely without using AC maintainer. I got so many beautiful videos. But there is only one problem in doing CCC. Even if you are doing through the side port, because of the fluid circulation, when you insert the needle in the side port, there is seepages of the fluid from the side port. No doubt the AC is maintained, but the flap there is tremulousness of the flap, and that is very difficult to catch the flap, especially with the needle. Forceps is a different thing, but with needle, sometimes it becomes very difficult. So what I do, when I do the side port with MER on my right side port is approximately say about 0.9 millimeters. So I just pass the MER and create only about 0.3 or 0.4 millimeters of opening. I don't pass the MER through and through before doing the capsule axis. Through that small opening, 26 gauge needle is passed, and then the capsulation is done. Because of that small opening, the chamber becomes more deep, and especially it prevents the turbulence of the flap. Once the capsulation is completed, I take the MER in my right hand and again go through the same side port and then make the proper 0.9 mm of side port, through which most of the times the capsule runs out. So this way you can do the capsulation as if you are doing under viscoelastic without any tremulousness. There is no time I can show you so many videos on this thing. Thirdly, with the AC maintainer, chances of choroidal hemorrhage is almost nil because there is no sudden pressure drop. Your pressure is always maintained. On the contrary, it is a high pressure surgery. The bottle height, someone asked, it should be around 60 centimeters above the eye level. And with 60 centimeters above the eye level, you are doing the surgery with 30 millimeters of mercury intraocular pressure. That is the pressure in the anterior chamber. But this is a pressure which is pushing the posterior capsule and the vitreous backwards. So you get a very deep chamber. Like capsule also is very well formed. So the sucking out of the cortical matter is very easy. You need not, there is no need of using viscoelastics also. Thirdly, because of the AC maintainer, there is continuous passage of the fluid from inside out. So less chances of infections are again there because nothing is allowed to enter the eye. On the contrary, I had asked this question to Dr. Blumenthal also when he was in Ahmedabad. Like we are doing the surgery under topical anesthesia. Once your wound is open, generally you avoid installation of the topical because of chance of it entering into the antechamber. But with the AC maintainer on, there is no risk of the anesthetic entering the antechamber. So during the surgery also, you can instill the topical anesthetic if the patient is having little pain. That will act as a surface anesthesia, and whatever is absorbed through the epithelium that goes inside. But directly the drug doesn't enter into the antechamber. That is another advantage. Secondly, because of the continuous sustained pressure, there is less chances of inflammatory substances. The release of inflammatory substances like cytokine, leukotriene. So again, there is less chance of postoperative inflammation. You are avoiding viscoelastics. So viscoelastics, though they are sterile, they contain a lot of endotoxins, which is responsible for TAS. That also can be avoided. Now, there are many situations wherein AC maintainer helps in case of PC rupture also. Many times you get a PC rupture, but because of the AC maintainer, the vitreous space remains intact and very meticulously you can perform surgery, continue the surgery. That is another advantage of AC maintainer. I have some videos wherein I have taken the lens from the, like the PC is totally torn, but without disturbing the posterior vitreous space, I have taken the lens and kept it into the sulcus, or sometimes I have done the capture. But these maneuvers have to be very slow. As far as the iris prolapse also is concerned, if the tunnel length is short, then there can be troublesome iris prolapse because of AC maintainer. On the contrary, if the tunnel length is sufficient, the AC maintainer also pushes the iris very much behind, except for the cases of floppy iris syndrome. So these are the tremendous advantages of AC maintainer. Now there are situations wherein you have to use viscoelastics. For example, initially when I was using Blumenthal technique, I was very adamant not to use viscoelastics, but you should not be adamant. Because see what happens in Blumenthal technique, the nucleus is undivided and round one. So effectively it blocks the scleral tunnel and the fluid water gets accumulated in the anterior chamber, it forces the nucleus out. But if you do the phacopragmentation or during the delivery, if the nucleus breaks, then the nuclear edges are very ragged one and they don't effectively block the scleral tunnel and there is continuous seepage of the fluid from both the sides. In such cases, and especially if some small epinucleus or nucleus remains, it is very difficult to take it out over a sheets glide because the fluid starts seeping from the sides. In such cases, I stop the AC maintainer temporarily and do visco expression because then it is more safe to do like that. Thank you.
Thank you, sir. It's like an encyclopedia of cataract surgery when you start giving your points. I would.
One more point. Can I add to this?
We'll come. Yeah. Please go ahead, sir.
See, this AC maintainer now, when we see bilateral cataract surgery done in PECO, they are doing excellent job, and my hospital also we are doing a lot. So, but without AC maintainer, we cannot give the similar kind of result. So all of us has to get conversant with this AC maintainer, because if phaco surgeons like my son is doing so many bilateral cataract surgery, and without any pad, people are allowed to go. So we have to reach there, then AC maintainer we all have to master. And I think we have to now think about this bleeding thing. Also, we have to think about how to get over this. So maybe with direct incision through that is what I'm thinking. We have to be comparatively uh, similar and if not better. So that is the frontiers. They have already so many surgeries I'm seeing Peko Chinmay is doing excellent results. Next day patient were so happy they skate a big wave. So I feel that AC maintenance is a must. Only thing we have to this AC maintenance what I have seen I was not using much, but Boramani is doing it for a long time. So I think we have to design the things which should be better because many a time it is inserting that also becomes traumatizing sometimes. Maybe I'm not very conversant, so I have to master these things. But I feel that we all have to learn. We all have to learn AC maintainer, and today's the presentation was good on the AC maintainer. So I think this is the take home message is that all of us have to master this, and if we have to now bilateral surgery is the going to be the in thing. So SICS also we have to do bilateral surgery, and we have to focus on that. Thank you.
Thank you, sir. I would love Dr. Arvind Moria to chip in and give us his thoughts.
Yeah, good evening, everyone. And at the outset, thank you so very much, Sahu sir, Buramani sir, and Gokte sir for this initiative of spreading knowledge regarding the M6. I call it M6. Right. So it is a savior in lots of conditions, undoubtedly. When there is pseudo exfoliation is there, where the endothelia is compromised and the pump leak hypothesis is not working well in those cases with the hardest of the cataract, and when the pupil is not so dilated, in those cases, the phaco is very difficult and great chances of endothelial damage. And few of the studies, up to 67% of the endothelia has been damaged while doing phaco, especially in those compromised corneal endothelium cases. So SICS is a savior in such kind of cases. I operated one pseudo exfoliation case 3 days back, HMSC, and today patient came with clear cornea, almost nil reaction, and 6/9 vision. So it's a great surgery. And now coming to the irrigating solution, that was a great talk. So my question from Joshi sir, that regarding the different these nucleus management. So is there what is his experience while the endothelial loss in different nucleus management technique?
Thank you, sir. In fact, we failed to measure the endothelial count because we do not have specular microscope as such. But clinically, whatever cornea on post-op day we see on slit lamp, that suggests that use of sodium hyaluronate along with HPMC along with BSS gives best result in all type of cataract, whether it is hard, soft, or whatever type of cataract. And that is what usually we are following in our center in all sort of cases.
So we did a world's first such clinical trial. It's published in IGO also in the special SICS edition. So we compared the Moria's technique of hydroexpression with the specially designed beveled up three-way hydrocannula that is attached to the BSS plus. And we compared it to the nucleus removal using the OVD. And the results were really surprising that we only know that the phaco is decreasing the IOP. But after doing the SICS, there was decrease in IOP and it maintained till 18 months. It was 8.7% in the OVD group and 7.5% in the BSS plus group. So SICS also leads to decrease in IOP. As we have seen in the congestive glaucoma, that 30% reduction is there for few years. And regarding the endothelia, the OVD group, it was 8%, and in the BSS plus, it was only 4.8% with significant p-value. So this was the first such study, and Gokte sir wrote a beautiful commentary on that article. Thank you so very much, sir.
Thank you, sir. I would like to call upon Dr. Mona Deshmukh, ma'am, for your points.
At the outset, thank you for being a part of this discussion. After hearing so many of the presentations and the stalwarts in SICS, what basically is important is if we have seen Dr. Gadre's slides and Dr. Damble's slides and Dr. Rajesh Joshi, any technique which has a less learning curve, even though if it has a less learning curve, it has to be mastered. Now, right from introducing the AC maintainer, what we were discussing was, though SICS comparatively has a less learning curve compared to FACOs, when we are struggling with the AC maintainer, initially as a beginner, if you have the right way to introduce the AC maintainer, the proper way that the endothelial or the Descemet's damage should not be there with not a narrow or a big maybe entry which may be a leaky entry, but few things if you practice from the beginning. Now it happens that if you start with a viscoelastic, you try to continue, and if you have mastered it, you just think that why to go back then go to an AC maintainer, which always needs a fiddling of that procedure. So if you are starting with an AC maintainer from the beginning and you have mastered it, anything which you have mastered it and is safe in your hands, yes, there are advantages and disadvantages of both. But if you have mastered for the AC maintainer, definitely all the points which Dr. Boramani has covered is definitely right from each step, maybe Rex's or the hydrodelineation procedure or the nucleus delivery or the IOL insertion or the even cortex aspiration from the subincisional the incision is very much easier as compared to the other procedures. So basically it is what I feel is once you have mastered it, you know what safe in your hand is, you know the prerequisites or the pre-planning of the patient, whether what's the grade of the nucleus, what is the endothelial count, whether it's a compromised patient, whether the patient is diabetic, having a metabolic stress in the endothelium itself, because sometimes it happens that we have done an uneventful surgery, maybe a phaco or SICS, a patient is diabetic, we tend to have a random blood sugar 200 plus, but still the next day you see some biomicroscopic visualization of striate keratopathy. So we are wondered why this so, though the patient or though the surgery was uneventful. So selection of cases, selection of the technique, expertise in your hand or whatever is safe in your hands, and at the same time weighing the risk and the benefit ratio is much more important. That is what is the gist I feel.
Thank you, ma'am. I would like to call upon Dr. Madhuri Dixit, madam, to give her expert opinion.
Good evening, everyone. First of all, I would like to thank Maharashtra chapter for giving me the opportunity to share my few thoughts on this topic. And I would like to thank Dr. Anil Shah for choosing this topic, because this is a very, very important topic. And today we had a very exhaustive discussion on which solutions, which OVDs. These are all advanced things. But the endothelial protection is not only which OVDs and which solutions we use. So as Dr. Mona says, I would like to elaborate on that. If we have any youngsters or the beginners here, there are so many other things where we can prevent endothelial damage by doing each and every step of the surgery intentionally. So preventing touch of any instrument in the anterior chamber itself is very, very important. Right from doing the incision and not doing too small incisions, even the side port. Most of the time, if the side port is too narrow, and too small, that gives rise to the endothelial folds. Because the beginners, they keep on introducing the instruments through the side port many times, that can damage the endothelium. So the having proper size and proper shape and proper location of the side port, as well as having a good dissection for the incision, is equally important to prevent endothelial damage. This is one point. Another point is, even I have coined one term called as a soft shell technique of nucleus delivery, where I say that the when you do CCC, the CCC should be the cortico cleavage. After CCC, when you do hydrodissection, it should be a cortico cleavage hydrodissection, where the nucleus is encapsulated in block. We remove the nucleus, so there is a soft epinucleus on the nucleus, and the hard nucleus is not bare. So when we deliver that, that cushion helps to protect the endothelium. And another thing I would like to say is we can definitely afford to spare some time to wash the viscoelastic, because we are not spending more time in emulsifying with any instrument the nucleus. So we can definitely afford to spare some time to remove the viscoelastic. And using viscoelastic, HPMC, most of the time, 99.9% cases, I used HPMC. And this is amazing. It is in between your both high molecular and low molecular weight. In SICS, we hardly need some protection of endothelium just while removing the nucleus. That's it. So the HPMC is best for that. And this is what I just wanted to say. There's one more point on your there's so much of turbulence in the case of when you use AC maintainer. I would like to ask Dr. Boramani, is there really no turbulence in when you use AC maintainer?
Yeah, there is no severe turbulence. There is no severe turbulence because if you see the air bubble at the center, sometimes there are air bubble, they remain steady. There is no turbulence as such. It is just the instantaneous replacement of the fluid, whatever has come out.
That's what I just wanted to add for the beginners.
Do we need to reduce the flow rates or the flow when we are doing the hydrodissections and the other procedures? For nucleus delivery, for cortex wash, it's fine. But procedures where we are doing hydrodissection and the same flow or the same, do we need to alter those? Because I don't use a AC maintainer, but still, is it
what I do,
tricky place?
Yeah. Generally, my bottle height is 60 only throughout the procedure. Sometime during capsulexis, if you feel that the antechamber is not deep enough, then I tell the assistant to raise the bottle height. So it temporarily deepens the antechamber more, and you can do the proper capsulexis. Or then in that case, you can use viscoelastics also to make it deep. And if the PC PC get rupture, then many times I reduce the bottle height by at least I bring it 1 foot down, so that the pressure also is less, and then all the maneuver should be very slow by reducing, because sometimes you don't know, suddenly something can happen and the iris can suddenly prolapse, vitreous also can come if the cement is kept on. So instead of reducing the flow means bringing the bottle at a lower height, and then very meticulously and very gently you can do the further movements.
That is what is noted once the rexis is getting completed, the flutter which we see at the end, that point is the crucial point where sometimes in SICS you need a big rexis for the nucleus delivery. So that is a point, valid point.
Now, if there is no turbulence, then why there is a flutter inside the AC?
No,
that is my question.
This flutter, if you put a small, like say 27 gauge needle through a regular side port also, there is a gush of fluid through that side port. That also sometimes causes flutter. So when I am doing the rexis, my side port is hardly 0.3 or 0.4. It should not be extremely narrow, so that the movements of the needle create fold on the cornea. You should easily be able to move the capsulexis needle but it should not be as wide as a regular side port. Only after completing the capsular exercise, again take the MR and then complete the side port. So it reduces the flutter a lot during the capsulolysis.
I think Arvind wants to say something.
Yeah. So, sir, my query is regarding when we are doing these high axial length myope patients. So, regarding the AC chamber maintainer, because it will further lead to further deepen the chamber. So, how to manage those cases?
In such cases, you can operate with a very low bottle height.
Yes, correct. Bottle height can be reduced. Yeah.
Yeah. Keep it at
Dr.
height of
Nikhil is
only
there.
Anything else we need to means the gauze needs to be finer.
How did they do that? Of course, they're not using
Unless there is a egress of fluid, unless fluid comes out, there won't be any flutter. So try to reduce fluid coming out from side port. If you make a larger side port, fluid will come out and that will cause turbulence. So try to avoid side port should be very small, as what Dr. Boramani said.
Yeah.
Okay. Later on, we can increase the size if needed.
Correct.
Yes. And bottle height is also really important. In each case, we can change the bottle height. I usually used to ask my assistant while taking out nucleus, reduce the bottle height. Sometimes as in a patient of myope, we can change the bottle height. We can keep it at 45 centimeters also.
If the pupil is,
Any different instruments to be used in such conditions?
Pardon, madam?
Any different instruments to be used in such cases?
I actually used beveled AC maintainer. I have not actually stressed on that, but I initially put AC maintainer with beveled up and then turned it down so that the fluid turbulence should be towards iris and not towards upward side, so that iris prolapse can be avoided.
Yeah, that is
So
a
I
great.
use beveled AC maintainer only. So the bevel, if it is on the inferior side, the flow will be towards posterior capsule and not towards superior side, so that iris prolapse can be avoided. And even shifting that bevel down will also avoid Descemet's tear. Initially, you have to put it beveled up and then turn it 180 degrees and put it beveled down, so that Descemet's tear can be avoided and the shift of fluid turbulence towards posterior capsule will be there.
Dr. Girish, in that case, is there any chance of fluid going behind the iris?
Not really.
If the pupil is dilated, is there any possibility of fluid seeping through the posterior to the posterior chamber?
Not really. Not really.
Hello, Dr. Nikhil is there. I think we would like to listen to Dr. Nikhil.
Yeah. I was coming to Dr. Nikhil now.
Good evening, everyone, and I really want to thank Team MSICS for inviting me for this wonderful webinar. Initially, I was really skeptical with the topic, what kind of discussion is going to be there, but at the end, I have learned so many new things, especially about the Blumenthal technique. I never explored it so much and personally never used it, and got to know that 80% users of Blumenthal. That was quite surprising. I just want to quote one line of my teacher. He always used to say, a good SIC is always better than a badly done FACO. So I think main objective of this society is to imbibe good technique in the new learning ophthalmologists, and also who are already practicing. And SICS is savior in many cases. So being a cornea surgeon myself, I really love endothelium so much, and I always try to protect it. And when we come across so many bullous keratopathies and do dissect cases, only that is the case where I have to use AC maintainer in my practice so far. But I'll definitely try Blumenthal technique in my next SICS case after watching so many videos. The turbulence factor, Boramani sir has given so many. The air bubble factor, it is really thoughtful that if air bubble is not moving, that means it is not causing that much of turbulence. So everyone should give it a thought and try this technique. I feel so. I just want to how SICS per se will help us in endothelial protection compared to phaco, I just want to point out on two things. I have come across few cases where I had to do a DSEC in the eye which was referred to me, and then the other eye was because it was a Fuchs endothelial dystrophy case. Endothelial count was around 900 to 1000. That's all. The cornea was hazy, but not exactly hazy, but the central corneal thickness was maintained around 550. The patient was advised primary endothelial transplant along with phaco, but they were not really keen. So in that case, I did SICS, a good done SICS than a badly done phaco. This was case done in 2019, and the patient is still surviving and maintaining the other eye even at 900 count. So definitely, we all should be excellent SICS surgeons to protect endothelium properly. And even in bad cases, bad cornea cases like Fuchs, SICS surgery itself is an endothelial protector, I would say, than a phaco surgery. And in post PKP cases, definitely the endothelial count at the time of transplant, even if it is around 2200, 2300, post surgery there is a lot of loss. Eventually, most of the cases will have 1500 to 1800 count when they develop cataract later on. So SICS would help in managing astigmatism also. So when there is good regular but higher astigmatism, planning incision, SICS incision on a steeper axis would help us to manage both astigmatism as well as protect the endothelium. So it would help doubly for managing astigmatism as well as protecting endothelium. So after a lot of elaborate discussion, there are hardly any few points left. So from my side, I would like to add these few points.
Thank you, Dr. Nikhil. Dr. Buramani sir wanted to make a point.
No, Dr. Ame, if you permit, can I show a half-minute clip of controlled CCC with ACM?
Sure.
Shall I share it? It is
Yes,
there on the screen. Yeah.
Sure.
Can you see my screen?
Yes, sir. The screen is visible.
Starting the video.
He has to choose between supporting his party.
So this is a capsular axis with AC maintainer without any viscoelastic.
The lady Pure Hampton. Back in September 2022, a transaction was secretly recorded. It's what Indians call a sting operation. A Korean-American.
Sir, can you mute your audio, please?
Yes, yes.
Partly because of connections with their family, but allegedly also because he promised to.
Somebody's TV is on, I think.
Sir, TV is on.
See, now I'm making the proper side port through the same opening, and mostly the capsule runs out of that. That's it.
Wonderful video, sir. So there's absolutely no turbulence, or there's no flapping. Yes, Anil.
Without any turbulence, the flap was very well controlled.
Yes.
Sir, one query, Buramani sir.
Yeah.
Yeah.
Absolutely, absolutely.
Dr. Arvind, we always SICS to UGs and PGs. We always teach.
See, many phaco surgeons are telling us that we have missed the bus. We directly jump into the phaco.
It goes with me also.
Phaco, presuming that phaco is the ultimate thing. No doubt one should learn the phaco also. But because of ISMSS now, the whole world is interested in learning the SICS, especially the countries where SICS is not an officially recognized surgery. For example, all the Gulf countries. Now, UAE has decided to invite me every year for their annual conference, and they are going to hold interim CCC in UAE in 2025 next year. That will be only our CCC, but not our regular biennial conference.
Right.
Yesterday only, Dr. Nitin Verma from Australia called me, and now they want to start SICS wet labs in Australia, New Zealand, and all Pacific region. In fact, now he's going to have a meeting with me in Bali, APO.
Right. So we must initiate an official proposal.
Yes.
To CIOS towards the NMC and all the DNB boards also.
Yeah.
Yes. Yeah, before we go,
Ames area was not teaching SSS, but they have decided to start teaching SSS.
Okay.
Great, sir.
Just coming back to the topic, I have a small query. There was a very important point in Dr. Rajesh Joshi's presentation where he said that RL is an off-label use in ophthalmic surgery. And we all know, we've all gone through this in our residencies. We extensively still use RL. So is there any medical legal exposure in using RL intraocularly when it is to be used only intravascularly? So all these seniors can opine.
I think what I have heard, there is no medical legal thing. You can use if your experience says it is good, because there is no clear-cut line on that.
And when majority
May I answer this question because I am a convener of AIOS Adverse Event Committee.
Yes.
Please do.
So these off-label drugs, they have been approved by AIOS, RL, and as well as bevacizumab. We are using it since many decades, so it can be used.
No, but my question.
Even Alcon, this BSS, it has clearly written that it is not for intraocular use. They have clearly written on it.
See,
Can I say something?
Everything is, if something goes wrong, then
Sir,
AIOS is there. This AIOS is there for all their members.
And it is written in the AIOS booklet.
Why I asked this
It is
particularly, I'll tell you. There was a case in Chennai wherein there was an endophthalmitis and it was taken out in court that RL was used. And the defense was standard of care by 90% of the ophthalmologists is RL, which was summarily rejected by the judge because BSS is available and is indicated for intraocular use, and RL is an off-label use. And there was a lot of compensation that the doctors required to be paid in that particular case. So fortunately, it is not the higher court, so it doesn't apply everywhere. But a precedent has been set wherein RL was not accepted as a standard of care in intraocular surgeries. So that is why I have asked this particular question. What is your thoughts on this?
Can I come in?
All these judgments, those who give they are many a time they don't know the science properly, and they can be self-contradicted. Many a time it is in Supreme Court is contradicting itself. So we are fortunate if we escape. We have bad luck if we get caught. So because there is no. So let us not bother about it. Let us enjoy the work. If misfortune is there, it can happen anytime. So why bother about it now?
Do we have some time? Do we have any time, or we are already late?
We are slightly late, ma'am, but Anil sir.
No, then I think we'll discuss next time.
Dr. Anil Shah wants to say something.
First of all, I am very much thankful to all the speakers and the discussant for giving this wonderful lecture and their opinion. But let me share my anterior chamber maintainer which I have designed. Hope you like this and you will also enjoy the design which I have prepared. Can I share for my anterior chamber maintainer in one?
Yes, sir. Yes, sir. Please go ahead.
Can you see the screen?
Yes.
Yes.
So see, this is my anterior chamber maintainer designer, which no one has shown in their video. Even Dr. Gadre has not shown. This is a 20 gauge needle, which is a blunt tip, and it's got two side holes. It can be connected to BSS RL or even 5 ml viscose syringe. The side wall is corrugated and it fits to the side port. It has got a bi-directional flow, so there is no turbulence, and there is no extra side port is required, as it can go through the existing side port which you have made for bimanual eye. This AC maintainer I have presented as a helmet in phaco and non-phaco surgery, and it is received award at the Vashi conference. This is available with Ankur surgical work, and it fulfills all the drawbacks which we have got a conventional side port AC maintainer. In the conventional side port, we have to make an extra side port at the 6 o'clock position, and here you don't have to make any side port. The existing side port you can use it, and from one side port, you can shift the AC maintainer to the other side port. The main important thing is that your chamber is stable throughout the surgery. There is no turbulence and there is no as such complication. And the another advantage is that this AC maintainer can be used with a visco also. Means if a 5 ml syringe is connected to the AC maintainer and if you use it from one side, then you can perform phaco surgery and you won't get any corneal injury or any corneal burn or even any corneal damage. When I used to do phaco, my assistant used to push viscous when I used to press the pedal, and when the needle start the sound, he used to inject 0.1 ml, 0.2 ml visco, and all the time chamber was stable and there was no turbulence and there was no disturbance in the anterior chamber, and chamber was throughout maintained deep. So I hope those who have not used this AC maintainer, this is available with Ankur Surgical Work, Kolkata, no financial interest, but this fulfills almost all the drawbacks of conventional AC maintainer. If you like it, you can use it, and you send me your views about that. Thank you very much for allowing me to share my AC maintainer.
Dr. Anil, you must have created your own version of each and every instrument.
One request, sir.
Anil, why can't you share a video?
The video, because I am not using nowadays, so I have not got the video, but I will share the video on the group actually in our SICS group. The video, it is used for SICS also and for the phaco also. Means you can use it in the phaco with visco, and as a BSS also you can use it. There is no extra side port required.
Dr. Anil, you are saying
Your name stands changed from Anil Shah to Innovation Anil.
No, thank you.
So my suggestion is, can we, yes, ma'am, please, you go ahead.
Can I? You said it's a 20 gauge needle with cannula with two side ports, two sides. So, and you're putting it through your regular side port.
Yes.
Normally, if we go by what Dr. Boramani said, we have to put in a 26 gauge needle through that. So then this 20 gauge, won't it make the side port very big?
No, this is for AC maintainer, and he is saying for capsular axis you make another side port.
So then another side port is required only in any.
Another side port is required for rexis. This is for maintenance of the anterior chamber. No, from one side port you maintain the anterior chamber, and from another side port you do the rexis.
No, you just said we can use our regular side port.
Regular side port, yes, from regular side port.
AC maintainer. But then for the rexis you have to make another.
That is there now. We are making two side port, but in conventional AC maintainer they are making side port at a 6 o'clock position. That is not required here. When we are using bimanual irrigation aspiration, we are making two side port.
Yeah, can I come in? Basically, I have only one side port on the right side, on surgeon's right side.
Yes.
The tunnel, and then one AC maintainer down there. Isn't it? So I don't make one other side port because I'm not using bimanual irrigation aspiration. Because if your AC maintainer is on, the irrigation is continuously coming through the AC maintainer. I have only aspiration cannula which is connected through a silicon tubing to a 5 cc syringe in my left hand. So it is like bimanual, but the irrigation handle you are not holding because irrigation is supplied by the AC maintainer. Even when it is it, so you need only aspiration cannula going through the side port for aspirating.
With this AC maintainer, you can do a bimanual irrigation aspiration also. So from one side irrigation is there, and from another side you can aspirate, and then you can interchange also. Interchange, and then you can aspirate from the other side.
Then you need two side ports. So instead of two side ports, I have got one side port and one lower tangential incision for the AC maintainer. But in addition, I sometimes take third side port if at all the aspiration of the cortex below the side port region becomes very difficult. Then sometimes I make one more side port and make the surgery safer.
I didn't think the webinar would last 2 hours, you know.
That's what I was coming to with the amount of wisdom.
One more suggestion. I won't take more than 1 minute.
Yeah, please go ahead, sir.
My suggestion is to Sahu sir and Boramani sir to have ISMIS sponsored multi-centric clinical trials to have higher level of evidences to prove these innovations.
And wet labs also.
Yeah.
Have wet labs for the PG students.
Exactly.
Absolutely.
And
Absolutely.
also for existing practitioners like me who want to learn.
And let ma'am be the spearhead.
I would love to.
Yeah.
Those who
Yeah.
have not used AC maintainer, they try this AC maintainer. I hope they will. It will satisfy all their requirement.
I'll try it. I will
We'll
try.
use it. We'll use it.
Sir, corrugated appearance of that, what we had seen, is there any advantage of that corrugated?
So it gets snugly fitted into the side port.
It snugly fits. Actually, Blumenthal's AC maintainer is not non-corrugated. Blumenthal AC maintainer is a flat one.
Flat one.
And whatever corrugated one Dr. Gadre has shown, it is a Levy type of AC maintainer.
Mhm.
I also prefer that type of AC maintainer because it snugly fits into that tunnel.
Yeah. So thank you, sir. As has been on display, the kind of discussion we have in these webinars is absolutely fantastic. I fail to remember the last time we had such discussions anywhere. This can go on forever with the amount of wisdom on display. So, but it's my job to conclude the session here. At the end, I would like to thank all the office bearers of ISM MSICS. I would like to thank all the three speakers for wonderful presentations and videos, and our discussants for the spirited discussion we had, and hope to see you again soon. Thank you, everybody. Good night.
Thank you.
Thank you. Good night. Good night.
Good
Thank
night.
you. Thank you so very much. Good night.
Wonderful, wonderful
Good
webinar.
night. Enjoy it. Enjoy it.
Thoroughly
Thank you. Thank you very much for wonderful discussion and a good webinar.
Ame,
Thank you.
put up the YouTube.
Yeah.
Yes, I will definitely
will be on
put
the same link.
all the
Sure.
videos and details. No problem.
Sure. Okay.
Sure.
Yes.
Missed
Yes.
it.
And on the group also, I'll put the videos of this AC maintainer. This is
Yes.
actually a wonderful instrument, and you try it, you will definitely love it.
I'll have to come to you, Dr. Shah.
Yes, you are welcome, madam. Always, you are welcome.
Bye. Good night, everyone.
Thank you.
Bye. Good night. Good night.
Good
Good
night.
night.
Good night.
Good night. Good night.
Good night, everyone.
Everyone, good night. Thank you.
Thank you, Anilji.
Thank you, Pradeep. मस्त झालं, छान झालं.
Thank you.
Girishji, it was very nice.
Gadre sir.